Hello, my topic is Influence of Good Death Perception, Moral Anguish, and End-of-Life Care Attitude on End-of-Life Care Performance of the General Hospital Nurse. My name is Nam-Joo. Introduction. Death is a natural phenomenon for humans. Some dies in their human homes with their families or relatives. Recently, due to the changes in family structures such as aging and nuclear familiarization, the number of the people dying in medical institutions is increasing. According to the National Statistical Office, 74.9% of the hospital and 15.3% of families were on their deathbed, and deaths on the hospital were much higher than those at home. It can be inferred that as the pace of the death is moved from home to hospital, care and management for deathbeds changed from families to medical institutions, and the proportion of the deathbed nursing in nurses' work is increasing. In addition, the majority of dining care and dining management of the elderly and chronically ill are transferred from families to various medical institutions and the nurse. However, research on end-of-life nursing has been conducted among nursing hospital nurses, hospice palliative care nurses, and the nurse who take care of the cancer patient. But studies on the clinical nurses at university hospital are limited. Most of the studied subjects were emergency room nurses who experienced death frequently, nurse on the intensive care unit, nursing hospital nurse who could prepare for death, and the clinical nurse at relatively severe university hospital. However, since most medical institutions, including general hospitals, operate mainly on this treatment, end-of-life nursing is performed without sufficient education on end-of-life nursing. This leads to anxiety about death when performing end-of-life nursing, and it is not possible to actively participate in end-of-life nursing with negative death perception and attitude. So, future research on end-of-life nursing by general hospital health management manager is needed. Recently, as awareness of the death and interest in good death perception increased, studies on good death perception are being attempted. In Korea, the term good death is unified, including both elements of respectful death and comfortable death. In previous studies, it has been reported that the perception of the good death among nurses affect their attitude toward end-of-life nursing. Nurses performing end-of-life nursing experience more distress in the various ethical dilemma situation. Moral anguish refer to an uncomfortable and painful feeling and an experience when moral decisions have been made about how to do it, but due to certain constraints, it cannot be moved into action. Hospice and palliative care severus and expanding under the life-sustaining treatment decision act, which took effect on April 7, 2020. Interest in death with dignified is increasing and moral anguish is increasing in many moral dilemma, requiring ethical judgment, skill in the providing dying care for nurse. This care attitude means positive or negative perception, emotion, and motivation of the nurse for the care for the terminally ill patient, which is a major factor determining the overall health and the quality of the life of the deceased and their families. Effective end-of-life nursing care previous quality care to non-variable end-of-life patient and take care of their families with love. Allowing patients to live comfortably and down while maintained dignified and die without rejection. The nurse's systematic end-of-life nursing performance is a holistic care to ensure the final movement of the life peacefully as the whole nursing for patients and their families, improve the quality of the life of the dying patient, and reduce the stress, anxiety, and depression. As for the performance of the dying nursing by intensive care unit nurse, the positive death perception and the dying nurse attitude and more death-related education they are received, the higher the end-of-life nursing performance. Therefore, it can be seen that in order to improve the performance of the end-of-life nursing by nurse, positive end-of-life nursing attitude and good death awareness must be cultivated, and education on end-of-life nursing is necessary. However, most of the studies on the good death perception of clinical nurse and the performed of end-of-life nursing were conducted on nurses in the elderly care family, cancer ward, and intensive care unit. Therefore, there is a need for the study on the effect of the good death perception, moral anguish, and the end-of-life nursing attitude on the performance of the nurses toward patients in the general hospital. This study attempted to identify the influencing factor of the good death perception, moral anguish, and death care attitude or general hospital health manager performing death care, and to provide base data for general hospital health manager to provide higher quality death care. To contents. 2.1 Research Design. This is a discrete study to understand the influencing factor of the good death perception, moral anguish, and end-of-life nursing attitude for overall general hospital health manager on the performing of the death care nurses. 2.2 Collection of the research subject and data. The subject of this study was 156 nurses working at 3 general hospitals with 300 beds or more, and 1 general hospital with 100 beds or more in 3 cities. The criteria for the selection, the target are those who have worked for more than 3 months with a dying patient, understood the purpose of the studies, and voluntarily agreed to participate in it regardless of the working department. The sample size was calculated with a significance level of 0.05 for regression analysis using G power 3.1.9.4 programs. An effect size of the 0.15 for power 0.80 and 18 predictors. A total of the 180 copies were distributed and in consideration of the dropout rate of the 20%. 174 copies were collected. Finally, 156 copies were used for data analysis, excluding 18 copies with insufficient or incomplete data. 2.3 Research tools. The tools used in this study have of the total of the 104 questions consisting of the 15 questions for the subject general characteristics, 70 questions for good death perception, 21 questions for the moral anguish, 30 questions for the dining nursing attitude, and 22 questions for the dining nursing performance. Each listed tools received preview perception from the other through email and paid for tools the required tools using free. 2.3.1 General characteristics. The general characteristics of the subject were measured with a total of the 15 questions, including age, gender, family types, education level, total work experience, current work experience, work type, job satisfaction, work satisfaction, religion influence, number of the amazing poor people's death experience, death-related education, and death care experience. 2.3.2 Good death perception. The good death perception was measured using the Korean version of the concept of the good death scale developed by the Stewart's et al. For medical students, nursing students, graduate students in life science, and nursing in hospice nursing activated. It has a total of the 70 questions divided into the three sub-areas, namely clinical symptoms, with focus on the clinical or biomedical aspect of the death process, intimacy, which is related to the psychosocial and spiritual aspect of the death process, and sense of the control, which is the ability to control consciousness, communication, and the physical function in the process of the death. Each item was rated using a 4-point Likert scale, ranging from non-important at all 1 point to very important 4 points. The higher the score, the higher the perception of the good death. In the study of the Stewart's et al., the relativity of the tool was the Cronberg's alpha 0.87, and in studies it was the Cronberg alpha 0.80. 2.3.3 Moral Anguish. Moral anguish was Min-Jung Lee's moral distress care for the psychiatric nurses by the Anguish's editors, with 21 items adapted, revised, and supplementary by the no editors. Each item was a rating used a 7-point Likert scale rating from experienced but not at all uncomfortable, 0 point, to very uncomfortable, 6 point, according to the degree of experience of the uncomfortable and the negative emotion about moral distress situation. The higher the score, the greater the moral anguish. At the time of the tool development, the elevatory was the Cronbal 0.90. In study of the null etiol, it was a 0.83, and in this study it was 0.95. 2.3.4 End-of-life nursing attitude. The end-of-life nursing attitude was measured using the attitude toward nursing care of the dining scale, developed by Bromelt, and modified and supplemented by the Joe and Kim. These tools consist of the 30 questions in 3 sub-areas: end-of-life awareness, end-of-emotion, and end-of-nursing. Each item was rated using a 4-point Likert scale rating from not at all 1 point to strongly agree 4 point, and the negative question was converted inversely. Score rating from 30 to 120 points. The higher the score, the more positive and end-of-life attitude. At the time of the tool development, the relatively was Cronbal 0.94. In the study of the Joe and Kim, it was 0.86, and in this study it was 0.78. 2.3.5 End-of-life care. The end-of-life nursing performance and the measure using the tool developed by the Bach and Che. This tool consists of the 22 items, the 3 sub-area, physical area, 8 items, psychological area, 8 items, and the spiritual area, 6 items. Each item is rated on the 4-point Likert scale rating from not at all 1 point to always 4 point. Score rating from 22 to 88, with a higher score indicating higher end-of-life nursing performance. In this study of the Bach and Che, the relevatory of the tool was the Cronbal 0.93, and this study it was 0.92. 2.4 Research process. The pursuit of this study was approved by the bioethics communities of the university after the prepared and deliberation of the research plan. For the surveys, 4 general hospitals located in the cities was randomized samples. The purpose of the study was explained to the head of the institutions and the head of the nursing department by the email or telephones and cooperation of the sort. The research proposed research method and participation method was explained to the target subject. Finally, the research was conducted among the nurses obtaining their approval and voluntary participation to the study. 2.5 Ethical considerations. The selection process of the subject and the proposal of the study was explained to the head of the institutions and the head of the nursing department of the 4 general hospital. After gaining their approval, the research proposal, the writing of the research participant, and all ethical methods of the research were explained to the nurses. Those who voluntarily participated were distributed with the questionnaires. The completely questionnaires were stored and encrypted for the separately. The data will be kept for the 3 years after end of the study. Then this will be sealed. A copy of the consent from the provided to the subject, and the subject who responded to the survey were returned with a small gift. 2.6 Data collection method. For ethical considerations of the studies, data collection was conducted from September 14 to October 15, 2021, after the IRB approval. After gaining the subject consent, a total of the 118 questionnaires was distributed and only 174 were recovered. It took about 15 to 20 minutes to fill out of the questionnaires, excluding the 18 respondents with the institute on the incomplete data. 156 completed surveys were used for data analysis. 2.7 Data analysis method. After data analysis using IBM SPS 25 inspections programs, the significant level of the result was 0.05. The frequency, means, and the standard deviation of the each variable in the general characteristics was calculated. The difference in the good death perception, moral distress, and of the care attitude and the end of life care performance according to general characteristics of the subject was measured by the t-test and 1A ANOVA. The correlation of the variables was analyzed using Pearson correlation coefficient, and the hierarchy multiple regression analysis was used to complete the factor affect the end-of-life care performance. 2.8 result. 2.8.1 General characteristics of the subject. The general characteristics of the subject. The average age of the participant was the 13.7.158 plus minus 10.22 years, and 52 people were the most under 29 years old. As for gender, there was the 150 women. A total of the 86% persons were married. The number of the graduated and university graduated was equal and 78 response. The average clinical experience was 9.62 plus minus 7.48 years, and those with less than 5 years had the most with 52 response. The average of the current hospital experience was 6.58 plus minus 6.20 years, and 48 patients had less than 3 years. The most common types of the work, the 3 shift with 112 people. As for job satisfactions, 90 people were most satisfied, and 81 people was satisfied with their job. Regarding the percent of the absent of religions, 83 people answered that they have a religion, and the degree of the influence of the religion had no effect with 68 people. A total of the 116 people said that they had no experience of the death of the family acquaintance without 1 year. No experience end of life education was the most at 83 response. In the case of the 73 people with educational experience, the most common education route was continuing education with the 33 people. The average month, the number of the nursing care for end-of-life patient had 123 response. These are shown in the table 1. 2.8.2 Subject to good death perception, moral anguish, end-of-life nursing attitude, and end-of-life nursing performance. Good death perception was 49.57 plus minus 5.67 points, and the average score was the 2.92 plus minus 0.33 point. Moral anguish was 18.65 plus minus 18.49 points. And the average score was 3.85 plus minus 0.88 points. The end-of-life nursing attitude was 18.5.64 plus minus 6.79 points. And the average score was 2.85 plus minus 0.23 points. End-of-life care performance was the 59.27 plus minus 10.01 points, and the average score was 2.69 plus minus 0.45 points. Table 2. Table 2, subject good death perception, moral anguish, and of life care attitude, and end of life care performance. 2.8.3 Difference in the good death perception, moral anguish, end of life nursing attitude, and end of life nursing performance according to subject general characteristics. Significant difference in the perception of the good death of the find in the job satisfactions, work satisfactions, and the average monthly number of the nursing care for dying patient. There was also a difference in moral anguish in the last education background, clinical experience, and the average month number of the nursing care for the dying patient. The characteristics they showed different in the end-of-life nursing attitude were final education background, end-of-life education experience, and the average month number of the end-of-life nursing care. The characteristics they showed difference in end-of-life nursing performance was job satisfaction, work satisfaction, religion status, and religion. 2.8.4 The relationship between the good death perception, moral anguish, and of life care, end of life nursing attitude, and end of life nursing performance. There was a positive correlation with good death perception, moral anguish, and end of life nursing attitude. Table 4 Correlation between good death perception, moral anguish, and end of life care attitude, and end of life care performance. 2.8.5 Factors affect end of life nursing performance. Multiple regression analysis using a hierarchy selection model was performed to test factors affect end of life nursing performance, and the result of the show in Table 5. Among the characteristics of the subject, job satisfaction, religion present, and the degree of influence of religion, which showed a significant difference in end-of-life nursing performance, were input into Model 1. The general characteristics were treated as dummy variables in Model 2. In addition to Model 1, general good death perception, moral anguish, and end-of-life nursing attitude was added. Job satisfaction was included from the analysis as it showed a higher correlation with work satisfactions as a result of the checking whether there is a correlation between the error terms before analysis. The Watson satisfaction was the 1.91, which is very near to. So there was no correlation between the error terms. As a result of explaining whether the distributions of the error terms can be assumed to be the normal through standard registers or variables with middle 0.3, so the distributions of error terms can be assumed to be normal. Table 5 Multiple regression analysis of the end of life care performance. 3-point discussion. The purpose of this study is to identify the factor affecting the end-of-life nursing attitude of general hospital health managed by the identified the variables affecting the quality or death perception, moral anguish, and end-of-life nursing attitude on the end-of-life nursing performance. An attempt was made to provide basic data, and based on the result of the study, we would like to discuss it as follows. 3.3 Effect of the good death perception, moral anguish, and the end-of-life nursing attitude on the end-of-life nursing performance. As an influencing factor on end-of-life care performance, in this study, it can be said that the degree of the end-of-life care performance is higher as job satisfaction is more satisfactory than dissatisfaction. The degree or religion's influence has an effect, and good death perception and moral anguish are higher. The total explanatory power was 27.3%. In a study by Kim, and Yoon targeting general hospitals, the experience power was 90.1%. In the other of the good death perception, education experience related to the life sustaining treatment, stress in the nursing care for life sustaining treatment, and knowledge of the advanced directive for the life sustaining treatment. End of life care stress was the most influencing factor in the study of the goal and moon. targeting intensive care nurse, and the experience power was 53% in the order of medical personnel and end-of-life nursing attitude with a subdomain of the end-of-life care obstacle factors. Unlike the previous studies, in these studies, new variables such as job satisfaction, religion, and more English was identified as variable affecting end-of-life nursing performance. In the future, it is necessary to check the experience power through related study, including the variable of the previous study and the variable of these studies. In order to positively change the end-of-life nursing performance, it is necessary to raising the awareness of the good death and to change the perception of the death by the preparing and interventing well-dying. Education program for those in the medical institutions such as hospital. The degree of the end-of-life nursing performance was higher as the total hospital work experience increased, which was similar to the study of the shown and bar, and the study of emergency room nurse of the shown. It is showed that there is a need for education program to positively raise the awareness of the death through the education of the nurse. The more spread the knowledge and the skill, and there are the less difference in the performing end-of-life care work. So it is showed that systematic education is necessary. The dying patient should not only focus on physical care, but also provide psychological and spiritual care. To achieve this, it is considered necessary to develop of the systematic nursing program. In this study, it is shown that the higher the professional knowledge and skill in end-of-life care, the less difference in the performing end-of-life care work. Therefore, it is necessary to improvement of the systematic end-of-life care nursing educational program to facilitate the quality end-of-life nursing. Communication problem and the lack of the time are obstacle to the end-of-life care performance. So hospital means and the head of the nursing department provide the communication related education to end-of-life care nursing and allocate the appropriate manpower so that nurse can actively and efficiently perform the end-of-life care. 4-point conclusion and suggestions. The purpose of this study is to present basic data helpful in the developing end-of-life care intervention program that can be applied to the clinical settings by the identified the factor affecting the end-of-life care performance of the general hospital nurse, good death perception, moral anguish, and the end-of-life life nursing attitude. Good death perception and the moral anguish were collected, and end-of-life nursing attitude did not show the collected with end-of-life nursing performance. Therefore, good death perception and the moral ungaining in the clinical practice have a significant effect on the end-of-life care performance. In addition to this variable, it was considered that it is necessary to give active and continuous interest and administrative support along with the effect to the identified other variables that experience end-of-life nursing performance. Based on the result of the studies, we would like to make the following suggestions. First, one in-depth study including variables other than good perception and moral anguish is suggested to the investigate the effect on end-of-life nursing performance. Second, based on the including factors of the end-of-life nursing performance, we propose an experimental study to develop an intervention program to increase the good death perception and reduce moral anguish, and to verify the clinical applications effect. Third, research on the development and application of a tool applied to nursing assessment and caregiving is suggested. Thank you.